Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape. The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello, good morning, good afternoon, good evening to everybody. This is Giuseppe Curigliano from European Institute of Oncology Milano and University of Milano, and I have the privilege to have with me today one of the best clinical scientists in the world, that is Professor François Clément Bidard from the Department of Medical Oncology of Institut Curie in Paris. We will do an educational activity together on evolving perspective on HR-positive metastatic breast cancer, and let's go now to François. We will start our educational activity with explaining to the audience an overview on the latest understanding of endocrine resistance. Please, François.
Yes, so thank you very much, Giuseppe, for the very nice introduction, and I'm very happy to be here. So I think that before diving into the, let's say, the mechanism of resistance for endocrine therapy, as we know them currently, it could be good to have a quick reminder about the mechanism of action of endocrine therapies. So we have many agents currently that we are using. So of course, aromatase inhibitor, and everyone knows that aromatase inhibitor will deplete, estrogens from in the body, so the tumor will starve basically, and will be unable to activate the estrogen receptor related transcriptomic program. We also are using SERM, so tamoxifen is a well-known agent and very old agent as well, so with an antagonistic activity on the estrogen receptor, so it binds to the estrogen receptor, but then it is kind of modulating the transcriptional program of estrogen receptor. We have also several agents, and so the third, so selective estrogen receptor downregulator or degrader, and these agents act by trapping the estrogen receptor onto the DNA, and because ER is trapped on the DNA, then the ER is degraded. And we have also a few new agents, such as PROTAC, and PROTAC are agents that aim at degrading so the estrogen receptor, and we have also other agents that bind to the ER, so named SERAN or SERCAS. So overall, these are estrogen receptor therapeutic ligands, so they bind to the estrogen receptor and they will prevent the transcriptional activation of the downstream gene. So if we look at what we know about biology that is driving to endocrine resistance, so we have several mechanisms that have been explored. First is the loss of estrogen receptor expression, so that's a very basic, I would say, mechanism of resistance, and which could be easily assessed. And I think that it's at the basis of our current recommendations, that is to re-biopsy our patient when they progress, or at least at the very beginning of their metastatic disease, to check whether the estrogen receptor is still expressed by the tumor. We have also more complex crosstalk signaling between pathways. So we know that HER2 pathway or PIK3CA, when activated, can also bypass so the blockade of estrogen receptor signaling. And most importantly, I would say, is that we also have mutations that could appear in ESR1, so that is a gene that is encoding for estrogen receptor. And we know that these mutations are associated with the reactivation of the estrogen receptor in spite of aromatase inhibitor therapy. And these mutations have been demonstrated to be very sensitive to the new cells, such as elacestrant and other cells that we will discuss a bit later. That was for the biology things. And then from the medical perspective, like we also have many factors that we know are associated with poor outcome under adjuvant or metastatic endocrine therapy, such as in the early setting, lymph node involvement. We know it is associated with a shorter times to relapse and also tumor grade. So we have like these basic pathological factors that are telling us that a patient could be perceived at higher risk of relapse. Whether it is truly related to the resistance of endocrine therapy or not is still, I think, a subject of debate. So that are the brief overview about the mechanism. We have also, to come back at the molecular level, we have many mechanisms that are involved, pathway, angiogenesis, and so on. So all of these, many pathways are converging toward, a single phenotype that is endocrine resistance. So, but let's move on to the management of HI plus MBC. So Giuseppe, could you please give us, let's say, an overview of your current treatment option and the ones that you are using in your everyday practice?
Oh, yes, of course. I will start from the ESMO clinical practice guidelines. So the first line treatment in HR positive HER2 negative disease is a combination of endocrine therapy plus CDK4/6 inhibitors. The only scenario where you may consider a chemotherapy frontline is the group of patients with an imminent organ failure, the so-called visceral crisis. This is quite a rare scenario, less than 3% of the patients, but in this specific case, we prefer to start with the chemotherapy. For the majority of the patients with HR positive HER2 negative disease, the best of care is endocrine therapy plus ribociclib, abemaciclib, or palbociclib, considering that all CDK4/6 inhibitors are not created equal, and you know perfectly that in the context of the ESMO magnitude of clinical benefit scale, we have a different score according to the benefit on median progression-free survival or overall survival. What to do in the second line? If you have a progression to first line CDK4/6 inhibitor and you are still an endocrine sensitive disease, so a longer duration to first line, the second line treatment is finally a biomarker based treatment. If you have a PI3 kinase mutation, you may consider a combination of fulvestrant plus alpelisib. If you have a PTIN deletion or a KT alteration, eventually you may consider the combination of capivasertib plus fulvestrant when it will be approved. If you don't have PI3 kinase mutation or AKT alteration, there is still a valid option like everolimus exemestane or everolimus fulvestrant based on the French data. If you have a germline BRCA or PALBA2 mutation, of course, you can consider a PARP inhibitor like talazoparib or olaparib. And finally, based on the data of the EMERALD trial, if an ESR1 mutation has been detected on digital drop PCR or an NGS, a valid option can be also considered elacestrant. What to do after 2 lines of endocrine therapy plus or minus biological agents? Here we have 2 different scenarios. If you have a poor sensitive disease, of course, with a refractory scenario, you may start directly with an antibody drug conjugated, even if in Europe the label is after 1 line of chemotherapy. According to the clinical practice guidelines, you can give 1 line of chemotherapy and then you can move directly to an antibody drug conjugated. Assuming you have an HR positive HER2 low disease, the best option is trastuzumab deruxtecan, based on the data of Destiny Breast 04. If HER2 0, the best option is sacituzumab govitecan. Following progression to TDX in HER2 low, you may also consider to sequence with sacituzumab govitecan. So, Francois, there are a few studies investigating new approach in the front line. Can you give us some overview. What are your thoughts on this trial, and what are the potential clinical implications?
Yeah, sure. So I think that the first line has been well established for the endocrine sensitive tumors. So and there are several trials that are currently ongoing, and so I will discuss them a bit later. So, but first we have to acknowledge that we had a very interesting trial that has read out at the latest San Antonio meeting, and that trial was so the INAVO 120. Phase 3 trial. So it was a trial that compared the addition of a new PIK3CA inhibitor inavolisib, so in addition to palbociclib and fulvestrant. And so we had two arms in this trial. So inavolisib, the PIK3CA inhibitor, fulvestrant plus palbo versus placebo, fulvestrant plus palbo. And patients to be eligible for this trial had to have an PIK3CA mutant metastatic breast cancer that was relapsing during adjuvant endocrine therapy. So these patients are, according to our guideline, eligible to a first-line treatment with fulvestrant plus CDK4/6. And here, because they had the PIK3CA mutations, they could have received on top of the two drugs inavolisib. And the results were really, very interesting, I think, and very convincing because they reported the median PFS of about 15 months for the patient receiving the triplet versus about half of it, so which was 7.3 months in patients receiving only fulvestrant and palbociclib. So I think that it really shows the clear benefit and the clear interest of using these PIK3CA inhibitor, so inavolisib in this context. And so we are waiting for the drug approval and for inavolisib to be available. I think in Europe, it's not yet available in France. I don't know for Italy, but we are definitely looking to get access to this drug. So INAVO 120 is clearly the hottest result we got last year, but we are also waiting back to the endocrine sensitive population to the readout of many trials that are currently assessing the use of this next generation SERD in the context of the first line endocrine sensitive metastatic breast cancer. And we have upfront trials. So we have the SERENA-4 trial, which is comparing the next generation SERD, the name of which is camizestrant. So it's camizestrant plus CDK4/6 versus AI plus CDK4/6. We have a very similar trial, which is giredestrant, so it's giredestrant CDK4/6 versus AI CDK4/6. So we have these two upfront trial head-to-head. We'll see whether the SERD could really demonstrate an improvement over the AI. And we have another strategy which is based on the Padawan trial. So we have the SERENA-6 study. So SERENA-6 is investigating the use of a very potent SERD against ESR1 mutation. So the idea is to track the appearance sequentially of these mutation of resistance during the first line. And when you see these mutations, that you know that the patient is becoming resistant or the tumor is becoming resistant to AI, then you act by switching the AI to camizestrant, which has already been reported to be extremely active on this mutation. So SERENA-6 is also one of these first-line trials to be watched with a readout probably next year. And we'll see whether the Padawan results are confirmed or even maybe improved. So these are the current, let's say, first-line trials, so results and ongoing trials that are in first line. And if we go back next to the second line, I think that we have like data that have been accumulated showing the interest of SERD, so this new class of agents after the acquired resistance to AI. And the Emerald trial that you mentioned is really interesting because it's the first trial with next-generation SERDs that demonstrated the superiority of this new class of agent versus standard of care, so fulvestrant, for example. So this phase 3 trial was a single-agent trial, so comparing single-agent elacestrant versus single-agent endocrine therapy such as fulvestrant. And both were given after progression on CDK4/6 inhibitors. So the PFS was short. Median PFS was about 2 months, but interestingly, we have many more patients who had a longer PFS with elacestrant than with camizestrant, with about 25% of patients still on the drug after 1 year on treatment. So which shows that we still have this, a significant part of our population is still sensitive to endocrine therapy drugs in the second line setting. So overall, it led to the use of elacestrant led to a reduction of 45% in the risk of progression or death, so which is very convincing in the ESR1 mutant population, and it has led to global approval, I think, or at least approval both by FDA and EMA, and availability. So that's the drugs that we are currently using in our ESR1 mutant patients. So that was about Emerald. And Giuseppe, I just wanted to come back maybe on the ADC trials, to what's new on the ADC, and also, most importantly, what are we waiting for, maybe at the ASCO meeting?
Thanks a lot for this question, of course. I will start reporting the details of the Destiny Breast 04, that, as you know, is a practice-changing trial. This was a prospective randomized trial, including patients who received the previous chemotherapy with HER2 immunohistochemical 1+ and 2+, and patients have been randomized to trastuzumab deruxtecan versus investigator choice treatment. The trial clearly demonstrated an improvement of median progression-free survival up to 10 months in the first analysis and up to 9 months in the latest median progression-free survival analysis presented during ESMO 2023. The only data that we are waiting for are the data of the Destiny Breast 06. Destiny Breast 06 is different from Destiny Breast 04. It is a prospective randomized trial who included patients without previous chemotherapy. And in the trial, there is also a cohort of patients with HER2 immunohistochemical 0, where 0 is intended between 0 and 1+. The primary endpoint of the study is median progression-free survival, and secondary endpoint is overall survival. We hope to present this data during ASCO 2024. Finally, we had in San Antonio some data on the combination of trastuzumab deruxtecan plus endocrine therapy, the Destiny Breast 08. The data of 2 arms have been presented, one with anastrozole, with an overall response rate of 71% and the median progression-free survival of 13 months, and the second arm with fulvestrant in the first line, a median overall response rate of 40%, and the PFS was not reached. Of course, we have also the data of sacituzumab govitecan that I mentioned before. This was a prospective randomized trial, including both HER2-0 and HER2-low population, that compared sacituzumab govitecan, that is an antibody drug conjugated against TROP2, versus investigator choice chemotherapy. The trial demonstrated that sacituzumab govitecan can improve the median progression-free survival from 4 months to 5.5 months, but there was an improvement also of median overall survival. In ESMO 2023, we had the data of a new anti-TROP2 ADC that was datopotamab deruxtecan. Here, the patient characteristics are a little bit different respect to the TROPiCS-02. Patients received a median of only 1 line of chemotherapy, so are less pretreated. The setting is very similar to the Destiny 4. Datopotamab deruxtecan improved the median progression-free survival from 4.9 months to 6.9 months. We don't have data, of course, of overall survival, and the majority of the patients received the previous CDK4/6 inhibitor. So we have sacituzumab govitecan, we have trastuzumab deruxtecan. We are waiting for the data, of course, of trastuzumab deruxtecan in Destiny 6 without previous chemotherapy, So, Francois, what's about PI3 kinase and AKT inhibitors? Are there any updates? Can you show us the data? And which patients could benefit from these emerging agents?
Well, so that's definitely something to consider. At least, it's uh, so we previously discussed the result of Emerald and the use of elacestrant in ESR1 mutant patients. But another option also is to consider the combination with agents that would target the PIK3CA, AKT, mTOR pathway. And so we have, let's say, two agents that are currently used and that have been used for years. One is everolimus, that could be used in all patients, independently of their mutation profile. And the other one is alpelisib, when or wherever available, currently not available in France, so which has, let's say, simplified our treatment choice over the past years. I think that in terms of everolimus, to be short, we had some data showing that it could be efficient after resistance to AIs. That was the Bolero 2 trial. But we had very little data about everolimus given after CDK4/6 inhibitors, especially in combination with fulvestrant. And if we look back to the ESMO guidelines, combination of fulvestrant and everolimus is highlighted as one of the treatment options, but we have, let's say, very few data, or at least no data from a randomized trial in this setting. So we recently published prospective cohorts that was registered, so consecutive patient and so on. And the median PFS we observed in patients who had received prior CDK4/6 inhibitor, and so it was palbociclib for most of our patients, was of about 7 months median PFS, which is not too bad, given, in the context of the other data we have. That's, I would say, that is very acceptable. But everolimus comes with some toxicity.
Thank you so much, because you know perfectly that we have other options today. One is alpelisib, that is an alpha-selective PI3 kinase inhibitor, and the other one is capivasertib, that finally is FDA approved for patients with the AKT alteration or eventually PTEN alterations. In the Solar One trial, that was the first one, but in patients never pretreated with CDK4/6 inhibitor, the median progression-free survival was improved from 3 months to 11 months. But then, when we moved in the BILIV setting, that was a post-CDK4/6 inhibitor, alpelisib plus fulvestrant versus fulvestrant alone, improved the median progression-free was a single-arm trial, the BILIV trial. And then the Capitello 291, that is a prospective randomized trial comparing capivasertib plus fulvestrant versus placebo fulvestrant in ER-positive, HER2-negative population. And the combination of capivasertib plus fulvestrant improved median progression-free survival from 3.6 months to 7.2 months, with no difference in the AKT altered population. Was very similar, 3.1 months versus 7.3 months. Overall, capivasertib now is a new option of treatment. And, I have a question for you now, Francois. So, what are the key considerations for CDK4/6 inhibitor sequencing? And then I would like to know from you if you have both alpelisib and capivasertib available and reimbursed, which would be your first option for the patient population following CDK4/6 inhibitors?
So that's a good option. That's a very good question. So maybe I'll start with that. Let's say in a patient that I'm not very confident to treat with a single endocrine therapy agent. So then with, let's say, a PFS in first line that is not very long, and so let's say 1 month, 1 year, or 1 year and a half, for example. So it's not that very convincing PFS and the CDK4/6 inhibitors. So definitely, I would look at to combine with a PIK3CA AKT mTOR targeting agent. So as I mentioned, so everolimus, few data and no gain in overall survival in the original study. So alpelisib, I think that in my, we used to have access to alpelisib initially in France, and in terms of toxicity, it was really tough. So based on the data, and there was also no overall survival benefits. So in the study, so I would say that I could be attracted by the use of capivasertib, which is apparently less toxic. There is still a bit of toxicity, but it's apparently less toxic than alpelisib. And there is also a strong signal in terms of overall survival, even though some patients may have crossover to other drugs. So I think it's, let's say, probably an innovation that I'm looking for. And of course, there will be a training curve with how to handle the drug, but I think that some patients will clearly benefit from this drug. So to come back to another option that is currently seen as a very, I would say, very American option. I'm not sure we are really using it in the clinics as of today for the second line, which is a recycling of CDK4/6 inhibitors after the first line with CDK4/6 inhibitors. So it has been, the idea of reusing a CDK4/6 inhibitors probably stemmed, I think, from the US label for abemaciclib, because abemaciclib has a label that is, as a single agent that could be given very late in the disease course. So some US physicians start to prescribe palbociclib or other CDK4/6 inhibitor in first line, but then also reused abemaciclib later on. And apparently, they have seen some activity, so which has again, driven some interest for this strategy. But so there are no phase 2 trials that have been reported, and so very small. One, the name was Maintain, a phase 2 trial, so it's 100 something patients reported, and they show a benefit in maintaining CDK4/6, but it was not really maintaining, it was a switch in the CDK4/6. Most patients received palbociclib in first line, so and were treated with ribociclib given in the second line. And apparently they use adding ribociclib to a single agent endocrine therapy in the second line setting showed some benefit. So there could be some benefit of switching CDK4/6. But then we also had 2 trials with palbociclib, and these 2 trials, so the name of them was PACE and Palmyra, so 2 phase 2 trials. And both of them both failed to show benefit of continuing palbociclib after palbociclib. So I think that there is a signal of activity that is coming, let's say, from the community, that it is somehow working, and it has been shown initially with abemaciclib. There is a trial with ribociclib given after palbociclib, so there is some signal. Obviously, we have to switch probably, and in that context, I have a very interesting trial that will read out later this year, which is the MBUS-3 trial, and it will be the first phase 3 trial to really test in one of the arm of the trials. It's a 3-arm trial, so they are testing so abemaciclib given after CDK4/6 inhibitor, and we expect most of patients will have received either palbociclib or ribociclib in first line. So it will be really like a second line trial with testing abemaciclib given after CDK4/6. So again, results that I'm looking forward to see. So that was about changing the CDK4/6. So currently, I would say it's not in my practice, but it could become really very easily implemented if MBUS-3 delivers some results. And so if we think about recycling or using a drug that is using always something very similar mechanism of action, Giuseppe, could you tell us about ADC after ADC? So what do you think? Are you doing it? Focusing on the HR plus population.
Yes, thank you very much for this question. What I am doing now in clinical practice is to sequence trastuzumab deruxtecan with the sacituzumab govitecan finally. But you know perfectly that we have some small retrospective analysis of ADC sequence. The first one was an MD Anderson study, including 469 patients, in which it was very clear that there was a difference in median PFS and overall survival when TDX or sacituzumab were sequenced across them, may be related to different patient characteristics. There is another small study from United States in which they evaluated the median PFS after ADC1 and ADC2, and it was very clear that if you give an ADC1, you have a median PFS that can be closer to 8 to 9 months. Then you sequence with an ADC2 with a similar payload but a different neoantigen target, and the median PFS is less than 4 months. Finally, we have the French multi-center retrospective study, and we confirm that the subsequent use of ADCs seems to be associated with a shortened median progression-free survival, both in HR positive and HR negative subgroup, independently of either administration order. So in my opinion, what we need to do for the future is to design clinical studies in which we sequence the ADC, having as a primary endpoint median progression-free survival too. So we need something similar to the SONIA trial, but in the context of ADC. So I believe now we have to give some conclusion. So I would like to invite you, Francois, to give your conclusions on the optimal treatment following CDK4/6 inhibitors, and then I will give an highlight on the ADCs. Please, Francois.
Well, just wanted to acknowledge that there are so many drugs in development in the ER plus space, so that it's really new. I think 5 or 10 years later ago, it was like we had very few drugs in development. So now it's changing. Like at every congress, we have new data, and it's really fascinating to see how it is evolving. So first line is very well established, CDK4/6 inhibitor based for most patients, AI given to the endocrine sensitive patients, fulvestrant given to the endocrine resistant population. So we are waiting for the approval of inavolisib in this setting, for the given with fulvestrant in patients relapsing under CDK4/6 in the adjuvant setting. So that's quite stable, and we are waiting for further trials. Second line, it's really tough. Second line, it's really choice. I think it's really heterogeneous between clinicians, and it's very difficult to deliver a recipe about whether, how to choose between the many treatment options, single agent, endocrine therapy, combination with PIK3CA, KT/mTOR inhibitors, or, as you mentioned, the ADC, because ADC are coming their way, and, they may end up as the direct second line treatment. So I don't know what you think, but I think, it's so we'll have more and more to discuss in the coming months. Now.
Yes, absolutely. I personally believe that when you have an endocrine sensitive disease, you should maximize the use, of course, of CDK4/6 inhibitor plus endocrine therapy, or any other biological agent plus endocrine therapy, because quality of life is better. And because personally, I believe we need still to manipulate the estrogen receptor pathway. Of course, when endocrine and biological therapy are exhausted, my first option will be for sure an ADC, also before chemotherapy. And I personally believe that waiting for the data of DESTINY-Breast06 can really reallocate an ADC in the first line setting. What we are missing, and we need to better understand, are mechanism of resistance to ADC that we still don't know that if they are related to the payload or to the target, and more studies on sequencing of ADC. So, Francois, thank you for this great discussion. And I would like to thank all the audience for participating in this activity. And please continue on to answer to questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.